fixing anything. We're getting the patient from point A to point B better than we found them, right? Normally it takes a whole bunch of other things for us to fix them. Usually it's antibiotics or some or an airway. You guys can do that better than anybody. But we're just getting that patient from point A to point B. And when you're pulling that patient out of the ER and you don't have the ability to titrate medications, like if you come through with a septic patient, you're taking them somewhere and it's a 25-minute trip, and you get them out in the back of your ambulance, and all of a sudden you've got maps of 40, what are you going to do? Like, where are you comfortable in titrating your medications? Are you comfortable doing that? So raise of hands, who's comfortable doing that? Awesome, 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 awesome. Okay, good job, Stella, I would hope so. How many of you guys are you guys do basic, advanced? What do you guys do here?
Advanced.
Advanced. Everybody here at least advanced then, okay? Okay, awesome. Then you guys can all do this, and when you're done here, you can be comfortable doing this, okay? So we're going to go over a couple of things. These are our objectives. On number 5, I'll show you how I do a simple valve calculation if your pump were to fail. I've had that because I've only had 3-channel pumps or a triple-channel pump back in the day. You guys have way more redundancy than that, so you probably don't have to worry about that, plus your phones are always working. I didn't trust anybody or my phone because it was always half charged, or something was wrong, or I'd left it at base or something. But the biggest ones, we're going to familiarize ourselves with our critical care medications. We're going to understand physiologically what we're doing, and then troubleshooting, I think, is the most important one. Like, okay, we've got this patient, we've got this med on, and now what the hell are we going to do? Because it's not happening, right? And then we're going to understand our signs and symptoms of effectiveness. Life is pretty much a good one. Yeah, they're alive. We're delaying death, right? Okay, we're going to overview these medications. We're going to go over thrombolytics and blood products, sedatives, still new year, sedatives and analgesics, critical care, cardiac meds, neuro and other critical care meds. What, just for funs and giggles, I went through summer with this, so I just want to make sure I'm covering all the stuff that's in your bags. But you guys, you don't do fentanyl drips, but you'll do push dose fentanyl, right? Okay, good. And then ketamine boluses. You guys doing a lot of that?
No, we don't do so much with the ketamine boluses unless we get orders from the doc.
Okay. From your medical control or from like my doc?
From the doc, the sending doc, what we
Okay.
call for orders.
Okay. How are you finding that they're pretty receptive to giving you things?
It's so long as you present it appropriately and you're giving them the appropriate dosage you want to give.
100%. I can't even tell you. I was in my office the other day, and I have a couple of new grads. I know you guys are shocked over that. I had a couple of new grads, and I could hear the vent from my office, from room 21. And I was like, WTF is going on here? Because that's not, I hate the sound of the vent. Usually it means there's some shit going sideways, right? And I walked in, and the peak pressures were 41. What should normal peak pressures on a ventilator be?
10.
Less than 30. If we're going anywhere above 30, we've effed up somewhere, okay? So I walked in there, and I'm like at 41, and I'm looking at this patient, and I'm like, WTF, like, what's going on here? No sedation, no analgesia after an intubated patient. And I was like, seriously? So I went to the doc, and I'm like, actually, I said, what the fuck? Like, seriously, dude, come on. I'm like, how about propofol and a fentanyl bolus, or even a fentanyl drip? And he was like, okay, yeah, let's do that. So 100%, if you are presenting it to any of these physicians, especially at Holy Cross Davis, and you know what you're talking about, you're good to go. They're going to give you everything that you want. But if you just go in there and be like, oh, I don't know. So hopefully this will help you just put your ducks in a row and ask for things, okay? All right, first thing, thrombolytics, similarities and differences. Back in the day, we did TPA. How many of you guys were transporting when we did TPA? Okay, do you remember how we did it? We did it in a bolus and then in a drip, right? So normally you guys would come through when we'd already given the bolus, but the drip was up, and it needed to be 60 minutes. And I can tell you multiple times that when I was flying with Stell, that I remember one time we walked into a hospital, and there's this patient, you can tell, needed TPA. The medication bolus had been given, and then I went to go like retrace the drip to put it on my own pump, and there was it was not attached to the patient. It was on the floor. The TPA was going onto the floor, and I was like, awesome, that's cool. That's how we used to do TPA back in the day. Also, that dose is done by kilos on your patient, and so at least 10 milliliters of that dose that you're giving to that patient is stuck in the tubing, and people would always forget to push behind it, so they would never get the full dosage. So when TN case came, and TN case is old, just know that right off the bat, but we've just started using it again because there's a couple of reasons why. So our TPA works for dissolving that blood clot and activating plasminogen, and then that produces plasmin. Plasmin breaks down that clot, and then doesn't allow that clot to get bigger. So the biggest thing that we're doing with either of these things, have you guys heard of ischemic penumbra? Okay, when you have a clot, what can you salvage that place where the clot was?
You're saying salvage the interior of the,
Where the clot was, where the necrosis is. I just gave you, no, you can't, right? So here's our brain. It looks like an egg. I'm not an artist, okay? Okay, so here's our brain, all right? We'll pretend this is our big old left MCA coming in here, M1, M2, M3, M4, okay? These are our vessels coming off our MCA, okay? So we get this big-ass clot right here, okay? This is decreasing flow, and we get those stroke-like symptoms that are going through there, okay? Right here, where this clot actually is and where the necrosis has happened, you're probably not going to get that back. But what you are going to get back is everything else that's downstream from that clot. And that's why we give TNKs, that's why we do LVOs. And LVOs, just a little fun fact on LVOs, not every stroke can have an LVO. Usually it has to be a large vessel, so an MCA right here, okay? And then, like I said, you have this M1, M2, M3, M4, which are these little, like, offshoots. When I was doing interventional radiology, we would go after the ones in M1 and M2, but M3 and M4 are too distal from the injury, so not every patient gets an LVO, which sucks. Hopefully one day we'll get better at them. Everybody will get better at them, but right now we're just doing M1s, M2s, and these big MCAs. So that's why if you've got that hemiparesis, you've got that paralysis on one side, we're like, go to where we can do an LVO. But you could be in M3, M4, and you still see that kind of stuff. So just a little food for thought right there. I only say that because we did LVOs until about 6 months ago, and now we didn't have the right equipment to do them. You need a biplane to be able to do that. It shows your brain in 3D. We didn't have that, and it's coming, but you know how slow hospital is. So doing LVOs at the KD or the U or IMC is the best thing for that patient with that type of stroke. Okay, so just off my tangent there. So we're trying to recruit back this ischemic penumbra. And we're going to do this in a few ways, and we're going to talk about all of this. Okay, remember neuro is my specialty, so that's why I kind of geek out over this crap. All right, so we're going to hit our TN case first, our TPA. Like I said with TPA, the sucky part of TPA was that it was a bolus followed by an infusion. It only had a 15 to 20 minute half-life. And what does that mean? So half-life means it reaches its maximum potential, and then it just starts to degrade after that. So it was only 15 to 20 minutes. It was super expensive. I don't know why we went there for the first place. And then post-administration guidelines for monitoring, these don't differ from either of them. What's the most important thing that you could do after you give TPA or you're transporting TPA on this patient? Your neuro checks.
Oh, like Cincinnati.
Mm-hmm.
Okay.
Yeah, because these guys, they have a 6 to 8% chance to bleed on you after this, and we'll go over the pathophysiology of why. But I cannot tell you or stress to you how important it is for you to be able to do every Q15 neuro checks after you've given this, or you're transporting this patient with a thrombolytic on board. Because it's not that you did anything wrong, it's that they will bleed. They can bleed. And if so you've got an embolic on top of a hemorrhagic, they're going to look a whole lot different from when you picked them up to when you drop them off. Being aware of that change is money. Not being aware of that change is when we're all just like, shit, we missed something, right? Okay, so the reason we moved over to TN case, it's the GMO of TPA, all right? It's genetically modified, and it just works better because it has a lot of different sequelae to it. It does the exact same thing. It does bind to that fibrin in a blood clot, converts it to plasminogen, which then converts that to plasmin. Breaks down that clot and restores blood flow. It's only a bolus. There's no drip. So we no longer have to go into a facility and have it going onto the floor, and we don't lose 10% of our dose in our tubing. So right there, Awesome, that's probably what we should be doing, okay? This is a kicker, 90 to 130 minute half-life. So it's reaching its maximum efficacy an hour and a half, roughly, after we've given it. So it's having that ability to break that clot down so much longer before it becomes ineffective, okay? The cost, I mean, any hospital, any place, you know, we're always looking to save a buck. That's the real deal there. It's half the price of TPA. And then this one, it's a max dose. So is this, but this is a little bit easier. It's 0.25 milligram per kilo, one dose, and we're done. Okay. This one over here, we used to have to take 10%, give it over a minute, and then do the drip. So it's a little bit easier in administration. Any questions on TPA versus TN case? You will never, I don't think anybody in the valley is using TPA anymore. It's all TN case. I think Leighton was the last one to pull up on that. Okay, couple of things to be considerate here about a blood pressure post thrombolytic. So there's a couple of things we need to talk about here. Okay. So remember when I'm giving you these blood pressure parameters, these are for embolic, thrombotic, post-TPA, pre-TPA, and hemorrhagic strokes. There's a difference for every single one. These are not for your cardiac patients. These are not for your septic patients. These are for brain patients, okay? And it's all so that we can feed that ischemic penumbra. All right. So the first thing, let me see if we're here. Okay, these are our meds here that we're going to be using. And it says subarachnoid treatment, but just understand that these are usable through all of our patients, okay? All right, so I'm going to go back here. All right, so we have a stroke, which is, we know it's either embolic, thrombotic. Basically, that just says there's a clot somewhere, right? And then we have hemorrhagic. Oops. Okay. Those are our three different types of stroke, okay? We give a thrombolytic on this one, or they require LVO, or sometimes both. We don't give any thrombolytic on that one, okay? All right, pre-thrombolytic. If I was said to you, I'm coming in, you're coming in to take my patient to the U or to McKay-D or whatever, and I'm like, we've not given any TPA, we've not given any TN case, pressures are 220 over 110. You gonna be pissed at me?
Mhm.
You don't have to.
Well, unless you're shooting for a gold or a high MAF or
Why am I?
just to feed it.
What was it?
Reperfusion.
Just perfusion in general, right? Yeah, you're right. So pre-thrombolytic, I'm gonna let that dude ride pressures of 220 over 110. That is so uncomfortable for everybody. When we see a pressure like that, first thing we're just like, oh shit, we're gonna like cause him to bleed or whatever, right? But in this patient, what we wanna do is we want to perfuse, remember my picture over here, we wanna perfuse this ischemic penumbra. We wanna perfuse all of that. And that patient requires that because A, we're going around a clot if we've not done a thrombolytic, and we're just trying to get back what we can get back. So you don't have to be pissed at me on this one, I promise, okay? Now, if you come in and I said, hey, we gave TN case, we gave 25 milligrams of TN case, and we are post-thrombolytic, and I say to you, my pressure is 220 over 110, now you can be pissed at me, okay? Where do we want to keep this pressure once we've given that thrombolytic?
40s.
A little bit more, a little higher. This is where we're looking at like 180 to 100. Okay, I'm not going to treat that pressure until it exceeds that. Okay, because again, I still want to I want to decrease my risk of bleed because it's 6 to 8% of these guys, like I said, they're going to bleed potentially, but I still want to perfuse. So we're kind of in this weird little sweet spot, and that's why it's so terribly important that you guys are doing these neuro checks along with all of your vitals. This is a Q5 that you're running this pressure. And you're doing these neuro checks every 15, okay, like no joke. Okay, now here's where everything changes. Okay, so you've got, well, let's just kind of go over here real quick. So you've got this MCA right here, right? Here's 1, 2, 3, and 4 again. what is the body doing the minute that that stroke or that embolus comes right into that vessel? What is your body trying to do? Because it knows it's there and it doesn't want it to be there.
Compensate.
It's compensating by producing an immune response. Okay, yes, an immune and a histamine response. So when we're doing that and we're trying to recruit all these white blood cells are huge, giant, okay? So when they come to this vessel and they go, this doesn't seem right, I'm gonna go take a look. So they'll pop little tiny holes into this vessel so that they can go in there, take a look, and start to do their whole thing to get rid of this clot. Because if you let the clot stay long enough, the body will figure out a way to get rid of it. You just don't want it to take 3 days, 5 days, 7 days, okay? So what it does is it pops these little holes in there. And here becomes your increased risk for bleed, okay? So this is why 6 to 8% of these patients will bleed, is because we've now created this area in this vessel that is these tiny little holes. And then if we don't have control over our blood pressure, we can cause these little holes to rupture and to break. And so that's when you can get a thrombotic embolic stroke that now becomes a secondary hemorrhagic stroke. And everything changes, or you can even have this one by itself, right? If you've got that patient, you've got a traumatic subarachnoid, or you've got an aneurysm, whatever. So those are hemorrhagic strokes, okay? So once we have that, where do we want to keep that pressure? Somebody said it earlier.
140s.
Yeah. We don't want it to go any more than 140s, 160s, over 80s, okay? And again, we still want to perfuse, but we want to decrease our pressure so we're not increasing our flow and we're not increasing our risk of bleed, okay? And we're going to do that with a few medications. Now, these are the medications you're going to be seeing as they're flowing and coming out of these ERs, okay? Okay, Cardine. Everybody seen that one? Okay, the other name for that one is nicardipine. All right, Keppra, 3%, and mannitol. That's basically what we're going to see. Now, all of these medications do different things, okay? The Cardine is the first one and the only one really that we're going to be using for blood pressure. You could use labetalol, but I like Cardine better. And as a whole lot of years in the ICU, I'll tell you why it works, okay? It works by blocking the influx of the calcium ion channels to the smooth muscle, and it causes dilation. And it's mostly arterial, a teeny bit of venous, but it's mostly arterial, okay? Titration if you need it. And then what's awesome about this one is it's not weight-based. So you don't have to F around with the mics per kilo per minute. It's just milligrams per hour, which is super easy, and you can titrate this bad boy up and down with a max of 15 milligrams an hour. Now, working in the ICU, I never ever had to go above 15 milligrams an hour. In fact, I've never had to go above 10 milligrams an hour. And there's a couple of reasons why. First off, this medication is totally tits. It's awesome and it works. It does the stuff. But usually if you're getting this patient, they're, I would say 50% of the time, they're going to be intubated, okay? So when you have a smooth muscle relaxer on there, plus a propofol drip, plus fentanyl drips, or boluses, you tend to decrease their pressure just in and of those things by themselves, because you're decreasing the pain in their head, because this hurts really bad, and usually they're tubed, so you're decreasing that pain in the back of their throat and the back of their trachea, right? Because the 8.0 tube is unpleasant. If you guys have ever had one. You ever had one? Sucks. Let me just tell you right off the bat. Sucks. And then you're also having this Cardine. So you're doing 3 different things. So you're doing pain control, sedation, as well as taking care of that pressure. That's why you generally never have to go over 15 milligrams an hour. If you do, you should probably add some pain medicine right off the bat if you're maxed out at 15. Okay? All right, Keppra. What do we use Keppra for? Seizures. Awesome. So if you've got blood in your brain, it's not an if you're going to seize, it's a when you're going to seize. And when you seize, and you've got all this crap going on to begin with, you've increased your cerebral metabolic rate, and you can cause a secondary injury. So remember, we're still trying to do this whole penumbra stuff. When we seize, we decrease our oxygen, and then we're increasing our area of necrosis. So what we want to do is decrease that from happening, and we're giving Keppra. This is one you do not have to have on a pump. This can be up, the nurse can hand this to you and be like, give this IV push. Fine, go for it, okay? This is really, you can do it IV push or over 15 minutes. I've done it both. You don't have any funky sequela that comes from this like you would with Dilantin. Dilantin potentially can drop the shit out of your pressure. This doesn't touch your pressure at all, okay? It's better than other anti-epileptics and it has way fewer side effects, okay? The funny thing about Keppra is that it's really, the way that it works, this mechanism is not really known, but what they suspect is that it kind of stabilizes the neurotransmitter to regulate the electrical activity in the brain, which I think is kind of cool.
Hey Nicole, isn't there more of a standard dosing on Keppra, like giving
Yes.
1 gram rather than weight-based?
Yes, so if, when in doubt, like on your little old lady grandma, you can give 1 gram over 15 minutes. On your big, huge biker guy, you can give 1.5 grams. And then they'll start getting that every 6 hours as needed, probably for the first 3 to 7 days of them being acutely in the hospital. There's some literature out also that talks about ongoing Keppra usage and how it doesn't really help them when they're in rehab. I don't understand the mechanism. I don't know why that happens, but it really is only in the acute phase of the bleed, okay? And remember, this is gonna be when there's blood in the tissue, so this is when you're only gonna have hemorrhagic. So on that embolic thrombotic stroke, you're probably not gonna see this, but on your hemorrhagic, yes. Okay? Okay. Oh, shit. I think I broke something.
Oh, it was me.
Okay. Okay. Do you guys ever see hypertonic saline when you're coming out of ER?
Not that often, but.
Not that often. 3% is kind of the pansy dose, and that's what you'll see in EMS. And when you're in the ICU, you can see up to like 27.6%. When you're seeing 27.6% at 3% saline, shit's gotten real. And it's gotten real fast, and we're herniating at that point. So we do this to avoid that crazy herniation when we're all just elbows and buttholes trying to get things to go. But this is what happens with hypertonic saline. Remember, our normal saline is 0.9. This is 3 times or 300 times more than that, or something crazy like that. 30 times more than that. I can't do math. I don't know. Okay, so what happens when you're in the ICU with a bleed and you have a shift, or even with a stroke and embolic thrombotic, and you've got that Monroe-Kelly doctrine, right? You guys remember that bad boy? When you have CSF, brain, or blood in the head. And it's box, right? You can't be like, it's not like a soft tissue anywhere. You can only fit so much crap in the brain or in the head. So when one of those increases, CSF, blood, or swelling, one of the others has to decrease. And usually what that means is it's going to decrease through that big giant hole in the bottom of your skull, and you're going to herniate. Okay, and then what's right there, right above that hole in the bottom of the skull? Your brainstem. What does your brainstem do? That's your sexing, you're eating, you're sleeping, you're breathing, your heart rate. Okay, that's all that stuff. You F that up, game over, all right? So what we're gonna do, we're gonna try and decrease that risk of that happening. So what happens is, normal sodium is what? 135 to 145? Yep. When we give this 3%, what we're shooting for is like 155, 160, which is kind of weird. And if you think about what we're doing there, is that you're basically, here's your vessel, and here's your normal sodiums all over the place. And then we're going to put a big ass influx of sodium. And all the tissues everywhere else in the body are going to be like, this is not homeostasis. I want to get back to my 135, 145. So what I'm going to do is I'm going to pull all the extra fluid everywhere that's in my brain, in the rest of my tissues, and I'm going to put it back in this vessel in order to dilute that right there. So that decreases the swelling. And what they'll do is they'll keep this at that 155, 160. It feels uncomfortable to have it that high, but it keeps it so that swelling can just decrease out of the brain. That's why we do it, okay? This is not a diuretic. It keeps the vessel pink, fat, and happy, which is another nice thing because then we decrease the risk of vasospasms here, and we keep that vessel because that vessel is going to like do some, it doesn't like blood around it. It likes blood in it, but not blood around it. So it can actually piss it off and have it like contract and stuff, like, again, another secondary injury. We'll do another calcium channel blocker on top of that, along with the hypertonic saline to keep those vessels pink and fat and not being able to squish them down. This is not a diuretic, like I said, so it stays in there, and you don't have to worry about your patient peeing all over the back of your ambulance. This is a different story, okay? How many times have you guys given this or seen this in a drip, or have you seen us giving that prior to sending your patient out? when we're giving that SIRF, that is shit got real funky right there. Okay, shit's real funky. Or shit's for real, however you say it, I got it backwards. Okay? This one is a diuretic, and it is an osmotic diuretic. This is the one where we do the peek and shriek in CT scan. And we've gone to CT scan, here's your brain, and here's your midline, and we've got this shift now. Instead of the midline going, it's over here. You can no longer see the ventricles here, they're all effaced. And so they're like, and usually you can see gyri and sulci in a CT scan, and when you've got big old swelling in the brain, that goes away. So you've got this tight as hell brain, and what's gonna happen? You've got edema, and it has to replace something, so it's gonna replace brain down the big hole, right? And we're gonna herniate, or we're already herniating at this point. So it's the peek and shriek. We're gonna give this fast, and it's gonna be IV push. On a healthy kidney, you will see this start to eliminate from the kidney in about 8 minutes. So if you do not have a Foley in this patient, so that's when you can be like, hey, throw a Foley in before we go, or if you guys want to do it, I'm down with that too. But you will have pee all over your back of your ambulance, I promise you. You'll be out of service, because it will be an amazing amount. Still, how many times did we do this? And with the Foley, you see 1 liter, 2 liter, 3 liters of fluid within about 8 minutes. That'll F up your day. Especially in the back of the helicopter. It wasn't awesome when that happened. What was that? Pretty much. You know how like when you open ambulance doors, sometimes you see blood coming out? It's just urine. So, yeah. On an unhealthy kidney, somebody who's got a chronic or acute renal failure, you're still going to see this elimination in about 15 minutes. So you might have a little bit of extra time, but they are going to pee all over you. Okay?
Placing bags over a liter, under a liter.
Seriously. And it's clear and it's scary when you see it, you're like, oh damn. But this can reverse a herniation, and you can reverse a herniation and still have some function in that brain. Now mind you, we want to avoid a herniation because, let's be real, when you herniate, it's like what you do get back is a copy of a copy, so you might not be normal, and this guy might be eaten with a cork on the back of his fork for a while because shit's not right. Okay, so we want to avoid that at all costs. Okay, what else can I tell you about brains and those medications? Okay, anything that you want to know more about them, or any medications that you've seen with stroke and or hemorrhagic embolic thrombotic strokes? Okay, if you come up with something, just holler at me.
And what's your recommendation on, you talked about titrating those meds. What's your recommendation on titrating?
Oh, thank you.
Medication 52, respond to miscellaneous fire at 2101 North Ford Lane in Layton. Medication 52, respond to
Some pretty
miscellaneous
aggressive
fire
titration
at
with cardine.
2101
cardine?
You're
So-
chasing your tail.
So here's what I do with cardine. When you're using cardine, and again, you're going to get that patient, and it's going to be going at like 5 milligrams an hour. I'm glad you said that, Jeremy. Thank you. You can go up by 2.5 every 5 minutes. Okay, so you start at 5, you can go to 7.5, you can go to 10, 12.5, 15. Okay. Once you hit your sweet spot, and you can do this Q5. Okay. Okay, once you hit this sweet spot, what's awesome is that you can dial it back then by 2.5. So you got your pressure that you want it to be, you got your 140 over 65, and you're super happy, and you're going at 10. At that point, bring your drip back to 7.5 milligrams an hour, and you won't have to touch it again. It's just that finding that sweet spot. But remember, you max at 15. If you're at 15, and you've got fentanyl in your pocket, or some sort of Versed, or anything like that, and you haven't given it, now's the time to give that. Okay. Right. Dissection. Okay. These ones are not my favorite. These patients can be looking at you, talking to you, and in the next minute they're dead. Because what's happening in a dissection? So we've got an aorta right here. Okay. Oh, shoot. Oops. Sorry guys, I went backwards. All right. Here's your aorta. Okay, and these are classified by DeBakey 1s or DeBakey 2s. Once it goes past the aortic arch, that's a DeBakey 1. Anything under and descending aorta is a DeBakey 2. Okay, this on your aorta in the inside is called a tunica interna, okay? This on the outside is called tunica externa. And what's happened with these bad boys is that you've probably had some super uncontrolled hypertension, and they're not taking their medications, or they just haven't done, they're just not following up, or this is new to them or whatever. Because you can have a AAA and have it like followed like every couple of months, and it can remain stable for the rest of your life. But usually there's a medication regimen and a whole bunch of other things that they're doing to make sure that's staying stable. This is that patient who's just like, F it, I don't care. I'm not going to take my meds, or I've run out of my medication or whatever. And what's happened is that you've got this shear force that's happening. So you've got pressure and you've got time. Okay, and when you have this happen, you want to change that pressure over time. Okay, so this is that patient who says to you, what do these look like when you get them? What's the signs and symptoms of this bad boy?
Anxious, anxiety.
Oh, horrible
Can't sit
amount
down.
of anxiety. We forget that one. And I think that is the first thing that you're gonna see. And they can't get comfortable, and that anxiety, so good. I heard tearing in the back, like back pain that's beyond anything that they've ever had, right?
Just sudden onset.
Sudden onset, I'm sure. What are their vitals gonna look like?
Unequal blood pressure, depending on.
Yeah, it really does, because you have that pre and post, right? Do you do that every time?
No.
That's a really that's like low hanging fruit. I mean, I appreciate the honesty, but this is low hanging fruit. If you've got a pressure of like 140 over 90 on this side and 180 over 100 on this side, you have to think to yourself, okay, we've got vascular problems going on, and that's what this is, okay? So if you've got extra cuffs in the back of your ambulance, just throw one on each side, and then just switch the tubing, okay? All right, so that's what these are right here, but this one, off the bat, this is the first thing you're gonna see, and then it's gonna be this one, okay? All right, so the first thing that we wanna do, if I was to just start carding on this patient to bring the pressure down, what would happen to the heart rate?
It's gonna go up, compensate?
That's right, it would compensate, right? Because the pressure's gone down, and the heart's gonna be like, oh, holy crap, I've gotta increase stroke volume, I've gotta do all that stuff. And the only way I can do that is with heart rate. So if we do that, if we decrease the volume, decrease our pressure, but our heart rate goes up, we're actually making the situation worse, okay? And they will rupture on you when you do that. That's a bad day when they rupture. It's game over. Just turn your monitor off because they've died. Okay. I've only had this happen one time, and it was with Cook. And we were in the back of the helicopter. We had just lifted from Evanston, and this dude's end tidal went from 33 to like 4. And I looked at him, and I'm like, shit. And he's like, yep, shit. And I'm like, okay, what do we do? And he's just like, because the guy needed a surgeon 10 hours prior to that. He had ruptured. And if you think about all the blood flow that's going through your aorta, you got about 90 seconds and you're pretty much done. And that's what he did. All right, so we're actually creating this shear to be worse if we don't drop that heart rate first. So the first thing that we need to do with this patient is a beta blocker. We need to not let this respond when we drop this bad boy, okay? So our beta blocker is first. Do you guys carry any? It's okay if you don't, okay? I don't care which beta blocker you use. I have zero preference, okay? First line is esmolol, which is a drip with a bolus, and then our second one is labetalol, which is just boluses. Labetalol is awesome. Because it's easy to give. I can give 10 to 20 milligrams every 5 minutes, and I can max out at 360 milligrams. So that's a shit ton of labetalol. You'll always get to where you need to be. The sucky part about labetalol, if you look here, is labetalol has a very long half-life. So can I overshoot the mark on that patient? Oh, hell yeah. So if I've overshot the mark and now I have pressures of 60 over 40, what am I going to do? Again, we're not fixing anything. Put a Band-Aid on it.
Give a little
We could do that. That could potentially jack this bad boy up. So what's a benign thing that we could do? Fluids. Oh my gosh, yes, fluids. Look at you running right to epi. You're like, push dose that bitch. No, it's just fluids.
If they're gonna die, they're gonna die.
Daniel, sit in the back.
Fluids. Do you want to hear a crazy ass story though? This is no joke right here. We had a nurse that flew the patient just like this. And it was on Christmas Eve. This was probably about 10 years ago. And this patient had a dissection that went all the way from the aortic arch all the way down to the renals. And you think to yourself, and he was 68 years old, had been a smoker, had coronary artery disease, as well, hypertension, as well as diabetes. Okay, so that's the trifecta of doom, right? And you think to yourself, okay, say goodbye to your family, do all the things. That mother effer lived. And I'm like, oh, that's just how? Like, seriously, right? Like, how did that guy live? So you can get them from point A to point B. We are delaying the death, but sometimes they just, no matter what we do to them, they still live. I'm shocked. Okay. All right. So the first thing we're going to do is hit our beta block. Whoa. Okay, labetalol, like I said, half-life super long, long-lasting. That's our bolusing, 10 to 20 milligrams incrementally. Every 5 minutes is needed, or we max dose it at 360 in 24 hours. If we overshoot the mark, our Band-Aid is fluids, okay? Totally fine to do that. Nobody will take away your birthday for doing that, okay? Where we want to keep these pressures is we want to decrease our heart rate below 60. And everything that we've ever been taught about a beta blocker is we don't give it if your heart rate's 60, but on a dissecting AAA or a AAA that looks like that, you're going to give it below 60, okay? Because again, we want to decrease that pressure in time and decrease that shear force, okay? Esmolol is my favorite. I just don't know everybody in the valley that if everybody uses it. It's a drip. It's a bolus actually started by a drip, and you can titrate this bitch up every 4 minutes if you want to. The thing that's awesome about it, it's called Breviblock for a reason because the half-life is about 90 seconds. So you have to just keep giving it. But you're doing that in your drip, which is totally fine. Did I say 90 seconds? It's 9 minutes because I wrote it right there, okay? Loading dose is big, 50 mics per kilo. Your drip is anywhere from 50 to 200 mics per kilo per minute. And you can go up pretty rapidly on this one. You don't have to do increments of 1 when you're going up. Go up by 10. So go to 50, 60, 70, 80, 90, 100, and you still have quite a few. And by the time you get to 200 mics per kilo per minute, you're going to be at your facility, okay? And then again, if you just want it in your head, if 4 minutes is like, how often do I do it? Make it 5, that's fine. Nobody will take away your birthday for that, okay? Nitro is another one, but just make sure that if you are using nitro, that you're using a beta blocker again. And also nitro is one of those patients that you're gonna see in a couple of different circumstances. Not so much for a AAA, but you're gonna see it in other patient populations. Do you guys know which ones those are gonna be? Okay, that's gonna be your chest pain going to cath lab. We have a cath lab, so you will never see that doing that. But if you're going from Layton to McKD or something, potentially you might see nitro going, okay? And nitro opens those coronary artery vessels, also decreases preload, so that's why we make sure that we have maps, right? And if it's an inferior wall MI, can we still give nitro? You can, but just be smart about it, right? Because if you drop that preload and you have nothing going back to that right atria and that right ventricle, have you ever done it? You don't want to do that. It's shit. And you will be chasing your tail all day long. But the best way to fix that, if you do it, fluids. Oh my gosh, yes. Okay, fluids fix everything, right? That's what we like to tell ourselves. Okay, so nitro, we can see that if they're going to the cath lab. But another thing that we might use nitro on, have you guys seen it for that pulmonary edema or for the CHF? Yeah, that's like one of my favorite ways to use it. You're doing nitro, BiPAP, maybe milrinone. This is rare. You probably won't see that a whole lot, but you'll see these, right? And this is like big BiPAP. This is like 15/5, 17/10, that kind of a deal. Because what you're doing with that pulmonary edema with that BiPAP,
Pushing the fluids out.
you're pushing it back, yeah. And you'll notice that their ease of breathing, once you stick that on there, it takes 7-8 minutes, and you're like, oh yeah, this homie's doing all right here. And then nitro for this, it's dilating all those arterials out so that you can increase diffusion across the board. So it's increasing how you're going to deliver this oxygen, okay? Now this is a big dose. So normally if you think about the little teeny tiny nitro that we're giving before with pre-hospital, that's 400 micrograms, right? 0.4, yeah, that's right. This is little compared to that, but it's sustained, which is super awesome. So 10 mics per minute. Ooh, sheesh. 10 mics per minute is where you can start. And titrate this fast. Like every 3 to 5 minutes, you can titrate this bad boy. Go to 20, go to 30. You can max out about 180 mics a minute. I've never, ever gone that far. I've maybe gone to 130 with that CHF patient, but you will offload that work of breathing just exponentially once you have that bad boy going, okay? What's one thing with nitro you need to watch out for? What was that?
Blood pressure.
Blood pressure for sure, headaches for sure, and then just watch, because if you don't have a beta blocker on board, you will see that heart rate go up, okay? Okay, any questions on those? Okay, we're just gonna cruise through these, okay? This is the #1 drug that we F up on. So, if you are doing an insulin drip, make sure you have a buddy who is looking at your dosing and checking off on it, okay? Because this can ruin your day if you take them hypoglycemic as opposed to hyperglycemic. And normally you're gonna get this in a DKA patient, right? You're gonna be transporting this. Those patients are fragile as hell to begin with. Their K is all jacked up, they're metabolically deranged, they aren't doing the things that you want them to do, their breathing's all effed up. These guys will punish you. So if you drop their you drop their sugars too fast or too slow because you had the wrong dose going, they're gonna punish you the whole way to wherever they're going. And you're gonna feel like a dumbass because you had it wrong, okay? So our starting dose, first off, 0.1 unit per kilo per hour. There should be a protocol that comes with this patient, and if you want to have it, great, ask for it. Because you need to be checking blood sugar on your transport. Please tell me you're doing that. Okay, and not just once during your transport, probably twice. Because these guys are so metabolically deranged that they will either chew up or not use any of their glucose at all. Okay, so if you have something and you did their first initial blood goal, you have their goal between 140 and 180, that's okay. We're gonna keep them a little sweeter than we are sour. The last thing we want to do is drop these bad boys into like the 70s, 60s, 50s, 40s, okay? These guys, like I said, once they're in the back of your ambulance, they start to chew the hell out of sugar. And so they'll drop pretty fast, which is, again, why it's super important for you to be checking the sugars in transport. This makes me uncomfortable, but that's how Summer said was fine. I would be like every 10 to 15, because that's how fast that they will go through stuff, okay? And here is the biggest thing, okay? When you're using your glucometer, they always tell us, please don't, use your capillary blood for your glucometer. These guys in a low flow state, which potentially most of these guys are, so those pressures are pretty crappy, their maps may be less than 65, don't use capillary blood because that's what your reading will have been from 30 minutes ago. So use venous blood in your glucometer, okay? Because that's really what's happening within the vessel itself, okay? Oops. Okay, these guys will always, always, always be hypokalemic. So please, please, please make sure that if you're taking a DKA patient out, that you are looking at the potassium before you get them onto your stretcher. And if they don't have a potassium rider on, get one. If they're anything less than 3.5, you need to make sure that they're having their potassium replaced. Their potassium must be on a pump. If it's not on a pump and it's free flowing, what are we doing? What are we doing?
Putting it on.
Yeah, we're actually doing euthanasia, like at the point of the mountain, because that's gonna stop a heart, okay? So don't do that shit. And then peripherally, 10 milliequivalents an hour is great. Central line-wise or IO-wise, you can do 20, and that's totally fine. But always, always on a pump. If I were to walk into a hospital, how many channels do you guys have? How many pumps do you have? 4. Okay, so if I were to walk into a hospital and I would see I've got 7 drips going on, I would be like, okay, potassium and insulin are getting 2 of those channels, no matter what. We'll figure out the rest. Okay, vasoactive drugs would be next for me. Any questions on that? You guys seriously, make sure you have somebody looking at your math. make sure it's right, because you will F this patient up hard if you don't, okay? Second drug that we F up on, heparin. This is another one that we need to make sure that we have our friends looking at our mouth, okay? If any of these are over 10 or 12 milliliters an hour, you've done it wrong, okay? Heparin, and actually, if you've done heparin, insulin, or vasoactive drugs that's over 10 to 12 milliliters an hour, it's wrong, I guarantee you. There will never be a time when you are giving heparin at 900 mils an hour, never. There will never be a time when you're doing epinephrine drip at 650 mils an hour, ever. Unless they're dying and they're doing this kind of thing, right? None of that will happen. So these are all low volume ones, so just keep that in mind. And if it's higher, you need to think, hey, this patient is really effed up or my math is wrong, okay? Heparin, we all know how this works. This binds to antithrombin 3. It doesn't allow, it basically inactivates thrombin and factor 10A, and then it stops producing fibrinogen to fibrin, and it stops clots from expanding, okay? Tons of usages on this. I mean, half our patients are taking this at any given time, okay? It's followed with a dose, initial dosing, then followed by a continuous infusion that's calculated on actual body weight, because this one is one that you've got a lot of adipose tissue. You could get a really giant dose, and it's not accurate. You don't need it, because it's working on the factors that are inside the vasculature, not on any sort of ideal or actual body weight, okay? And this should be, say, ideal, I'm sorry. And it's often capped to minimize bleeding. IV pump, 100% mandatory, double check with your friend. And your antidote is protamine. Anybody know where protamine comes from? Here's the story, okay?
Salmon, semen.
Boom, salmon season.
Cheater.
Some dudes out in
I'm the one
Alaska,
that found
That's
it
the
out.
only thing you held on to.
you know what, that's cool, that you remembered that. I'm super happy with that.
I mean, you got a red patch for the day, like, that's the one thing I would expect.
So some dude out in Alaska was fishing, and he says that as he was gutting his fish, his hand went through the semen sac of the salmon and into his hand, and the protamine within the semen sac of the epididymis of the salmon. Who knew epididymis on a salmon? No idea. But it actually coagulated, so that was kind of cool. So it turns basically, heparin is acidic, protamine is alkalytic, and it just basically neutralizes it.
Oh, that story's a little suspicious.
I think so. I call bullshit on that. Like, I don't know what you were really doing with that salmon. Yeah, sick turd.
We need more Peter on this.
Yeah.
Seems a little too convenient.
The fact right there that I found salmon semen made me super happy. Always, here's your fun facts for heparin, you guys. PE and ACS, so that's pulmonary embolism and acute coronary syndrome bolus, are anywhere between 60 to 80 units per kilo, so it's a huge and giant bolus. And then your infusions, depending on your facility, is anywhere between 12 and 18 units per kilo per hour. Your bolus max is between 4,000 and 5,000 units. You won't have to do that. We'll do that. And then it will always, 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 always be in a pump. Okay? And so here's your example of your calculation. Your 75 kilo patient, 12 units an hour per kilo per hour, 900 units an hour at 100 mils per unit, 100 units per mil, you set your pump at 9 mils. If it's at 90, you've done it wrong. Okay? That's across the board. Okay. Are you guys worried about blood administration in any way, shape, or form?
Call you guys.
Okay. The biggest thing about blood administration in the ER as opposed to blood administration on the floor, like med-surg, completely different animal, right? The reason that we're giving blood in an emergency setting is because they're bleeding it out and we can't get it in fast enough. So, if I can tell you anything besides protamine and salmon sperm, is that you get this shit in as fast as you can, okay? And I'm gonna hand you more units as you're going out the door. And within those units, you probably have a different donor every single time. So the potential to have a reaction every time you start a new unit of blood is usually within the first 10 to 15 minutes. And what that's gonna look like is, this is where I'm worried that we've given the wrong blood type. This is a normal histamine response. You're gonna potentially have that with every blood unit that you give. Itching, fever, chills, hives, and you can treat that with Benadryl and Tylenol. They tell us in theory to discontinue that and let your doc know. And if you're getting it from my facility, please bring it back to me so that we can test it and see what went wrong. Hemolytic reaction is a completely different thing. This we expect This we never want to see. This will F up your day, okay? This is because a B positive patient has gotten an A negative blood, that kind of a deal, or vice versa, okay? They get this crushing chest pain. The impending feeling of doom, yeah, that's real, yep. They'll say that, I feel like I'm gonna die. They will have trouble breathing and you will have to tube them en route, I guarantee you. High fever, and when I mean a high fever, that's anything over 101.5, because your histamine response is just being dumped into that patient, okay? Nausea, vomiting, hypotension, you'll actually have, it almost will look like anaphylaxis with their pressures, and it will just basically have a vascular collapse. Dizziness and reddish brown urine, and the reason we're having reddish brown urine is because we're having rhabdo going through that. So what are we gonna do here? How are we gonna fix this? It's gonna stop the blood for sure. And then what are we gonna do? What was that?
Diesel.
Diesel. And our ABCs, that's all we care about, right? That's pretty much what we do in EMS, ABCs. We augment their airway in any way, shape, or form. We make sure that their breathing is intact and that their circulation is intact. So this could need fluids, this potentially could need epi, this could need all that kind of stuff, okay?
And Nicole, you kind of raised another question with, you said if something occurs, bring the blood back to you.
Mm-hmm. Yeah.
Who is actually, because the receiving facility is they're gonna want that as well.
Yeah, so I would
And
just
so how do you, like, who actually has
In
a
a
stake towards that blood?
in a
getting back?
hemolytic reaction, it's gonna be us, because we fucked up. 100%, somewhere we fucked up. That A positive patient just got B negative blood.
Yeah,
Somewhere, and we need to be able to go back, diagnose that, where that happened and where in the line. If you can't bring me the blood itself, and you've got, because you stopped this blood, right? You stopped it. So just bring me a tube of it, I don't care. We just need to make sure somewhere along the line, some product has gotten jacked up. Red blood cells are the only one that need to be type specific, or you get the O neg. FFP and plasma can be anything, just remember that, okay?
I just wonder, because that's gonna be kind of an awkward line to,
Yeah.
because they're gonna want it, and
Yeah, or
their
you can
workers
call
gonna
me,
want it. and-
Or you can call the receiving or the sending facility and be like, hey, this happened, and I'm gonna be like, get me on the phone with them. And I'll be like, give them some blood to
So
bring back to me.
defer is your recommendation.
There you go, if you can't get it, call a friend, phone a friend,
Got it.
okay? In my 25 years, I have seen this only one time. I didn't do it, thankfully, but I've seen it in the ICU. Okay. And it was right after a huge MTP. You would think that wouldn't do it because we changed their blood supply at that point, but it did. A
And
huge-
do you guys send typed blood, or is it, are you mostly sending on that?
Oh, no, we'll send you some typed if we have it, and if they've been there before, if they've been there, or if they're that bleeder that's coming, or that stable GI when they came in, we were given blood and then their varices popped. Yeah, we might have type specific. But most of the time it will be O neg. On a dude, don't be shocked if you see O positive, because we really don't give a crap about RH factor on a dude, because they're not gonna have an RH reaction. Females for sure will get O negs. And if they're postmenopausal women, you might see O pos as trauma blood. Okay. Okay, you guys do this better than anybody else. I've been through a lot of, I picked up patients from a lot of agencies, and you guys know how to do this. I really feel like I'm just whatever being with you guys. You guys take care of your patients really well as far as sedating and intubating and having analgesia. The one thing that you may see that I just want to bring to your attention is propofol is the way that we used to do things. You're going to see less and less of that because of all the shit that propofol causes, okay? Propofol causes hypotension if you're allergic to soy and or eggs. Potentially you could have an anaphylactic reaction. Never seen that. But it has zero pain properties or pain managing properties. What you might see in the future is this, and if you don't have a tube when you're transporting this patient, you're doing it wrong, okay? Because you can drop their, you could totally decrease their respiratory drive, and that's, remember, this is Michael Jackson drug, we all know this, okay? All right, Precedex is just money. I freaking love this. This is sedation, but it also has pain medication on board with it, inside of it. And then minimal respiratory depression. So this patient doesn't need a tube. But if you need to sedate them, this is a money drug. I freaking love this drug. I'm trying to get all my boys in the ER to use this more and more often because it's just tits. I love it so much. It just does the work for us. This is great, and it doesn't touch your pressures, So if you've got that patient who you're having to pace externally, that sucks. Have you guys ever had that happen? I mean, you're getting, 60 to 70 milliamps transcutaneously, it blows. You get this on board right there and it doesn't drop their pressure, where this will, and they're happy campers. They don't hurt and they're sedated, and it is awesome. The only sucky part with that is it can cause bradycardia. So if you're pacing, that's not the correct place to do. But atropine will fix it. Okay. Where this will cause profound hypotension, that if we cause that, it takes a while to get back, and how do we get it back? Fluids, yeah. Okay,
What's the half-life of the precedents?
it's super short. I think
Is it on the same lines as propofol?
yeah, I think they're both about 6, 7 minutes. So when you stop it, it takes about 6, 7 minutes to clear. Okay, you guys don't do fentanyl drips, but you do titrate boluses. Remember the biggest thing, short-term pain control has some sedative properties. You see it mixed with all of our street drugs lately, and these are the overdoses that go real bad when it's mixed with fentanyl, because it really takes out their respiratory drive. Must be continuously monitored. You guys know the reversal better than anybody. And just make sure when you're giving this, again, this is about a half-life of about 6 to 8 minutes, 6 to 10 minutes. So if you're doing a fentanyl bolus, you're gonna have to do it again during transport. 25 to 50 is fine, okay? Ketamine drips, these is awesome if you're gonna be taking out the, I think the only time that you're gonna see a ketamine drip coming out of the ER would be that patient who is asthmatic. Because it's sympathomimetic, which means it mimics the sympathetic nervous system, and it will open those bronchioles and those bronchi just exponentially. So this is amazing for an asthmatic patient. Remember the dissociative, it's dissociative depending on doses given. I've only had one emergence phenomena in my whole life, and the guy screamed the entire time he was getting ketamine, and then when he came out, he was like, I know what red smells like. That's what he told me. And I'm like, I believe you, bro. And I'm freaking out over it because a screaming ketamine patient, not awesome. You can use these boluses for pain, 0.3 to 0.5 mg per kilo. And then your drips are anywhere from 0.5 to 5 mics per kilo per minute. Half-life, they'll dissociate for hours, which is super awesome. Then you can do your thing, drop them off. I told this story last time I was here. I had a patient that I picked up on the ski slopes over by, I think it was Snowbird or something, and he had 2 angulated femurs, and that shit hurts, right? Like, even over the rotor wash, I could hear him screaming. So as we're walking towards him, I'm pulling up the ketamine. I gave him a pretty big dose, and by the time we had him loaded in the back of the helicopter, he was like giving me the heart signals and telling me how much he loved it. So it's an awesome drug. We don't utilize it enough. And on kids, oh my gosh, yes, kids. Okay, because it's like the lights on, but nobody's home. They don't give a shit what you're doing. Okay, antibiotic administration. I don't want you guys to think too much about this. You guys already know about Ansef, it's ceftriaxone. These are IV push. If it's not one of those things, it goes on a pump. End of story, okay? And it doesn't really matter how long it will be, because you could do Zosyn or Cleocin, and that might finish by the end of your transport. That's okay, just flush the line behind it. If it's Gent or Vanc, that will not finish by the end of your transport, okay? But everything else, with the exception of those two, goes on a pump, okay? Signs and symptoms within your allergic reaction will be within 15 minutes of starting that antibiotic. So probably just in time that you guys get them in the back of your ambulance is when you'll start seeing itching, shortness of breath, all that kind of stuff, okay? Discontinue if that happens, and support those patients' vital sign. If they're anaphylactic and their pressure drops,
Fluids.
and then all your epi and the other stuff, right? Yeah, and when you see us giving stuff for anaphylaxis, we don't just give epi and fluids, we also give dexamethasone and Pepsid. And the reason why, just as you guys know for fun, is that, and Benadryl, we give Benadryl as well. You guys have that, right? Yeah, Benadryl's like one of my favorites, all over. But Benadryl, so the epi obviously will stop the histamine response from happening. Benadryl will stop the symptoms from getting worse. The dexamethasone and the Pepsid will stop the symptoms that are happening 6 hours later.
62.
Have fun.
Good luck.
662.
Have so much fun.
And the Pepsid's also given to you, is it the, an H2 blocker?
Yeah.
Yeah, on top of that, which is, complements that benefit as well.
Absolutely, and the Pepsid
is
will
the
last for
H3.
about 6 hours. What was that?
Isn't it Benadryl H3?
It is histamine blocker. Okay, Levofed. You guys will see this coming out of the ERs, okay? The biggest thing that I can tell you about this is please titrate it if you need it, okay? This is indicated in that severe hypotension, septic shock. They also have to have fluid on board prior to this. The biggest thing, I think your guys' protocols are mics per kilo per minute, is that right?
That is correct.
Okay. You'll see us at Davis because I don't know why Common Spirit is so stupid about this. This is the one thing that really pisses me off. It's bikes per minute. I prefer body surface area because if you do get those fluffier patients, you're going to need a little bit more because the adipose does make a difference in that one. So ours will be mics per minute. Oops. So if you are not familiar with that dosing, just ask your nurse and she'll tell you where to go with that, okay? Or you can move it back to your mics per kilo per minute onto your pumps. You do you, okay? The biggest thing about this is that you can give it through an IV, IO, central line, wherever you want to. But the biggest thing that Summer wanted me to let you guys know is overshoot the mark when you're starting this. Like when you throw this Levofed onto your patient, don't wait 15 minutes to get a MAP of 60 when you've got a MAP of 40. Go big and then titrate back down. So for me, when I throw a Levofed drip on at mics per kilo per minute, I'll start at 0.1 mic per kilo per minute, which is a lot. And then once I get my pressure, I'll just start coming back down. And usually you can find a sweet spot between 0.03 and 0.05 mics per kilo per minute. But shoot high, get to where you want it to be because you want to perfuse, and then start dialing it back. And Summer is 100% down with that, okay? If you are leaving my ER and you've got 0.1 mics per kilo per minute and you've still got shitty pressures, at this point you need to say, okay, we need to add a secondary. And the secondary is vasopressin, okay? And the reason why is normally if you're taking this patient out of the ER, they're in septic shock, okay? They're in anaerobic metabolism. Remember, that's the difference between 2 ATP and 336 ATP or something. So they're going to be acidotic as hell. And once you get to a certain point of a pH of 7.2, Levofed won't work as well. And because it is in that acidotic environment. But vasopressin is endogenous and it's produced by the posterior pituitary. So this will work in acidosis. So you throw this bitch on with that Levofed and your money. You don't have to keep titrating up. You'll actually start bringing your Levofed down. Vasopressin is one that you just like 0.04 units per minute. And it's usually 20 units in 100 mils. That's standard. You could just set that bad boy on your pump for 12 mils an hour and leave it alone. Don't touch it again. But if you're leaving, you don't have to know all that. I'll know all that. But the thing that if I'm asking you to take this patient out with crappy pressures and you're maxed, ask for another method. Okay? There's multiple ways to skin this septic cat. Okay, questions? It's a lot of information. I know, sorry you guys. Any questions?
What did you say after mannitol?
Oh, you can have this whole thing. One thing, let me just go back real quick. One thing that I didn't tell you, if you've got that herniating patient, head of the bed greater than 30. Yeah, position, huge, because you decrease their ISKP by making sure that those carotids and everything can drain. And then also look at your C-collar. Make sure they're not cooked to one side and that you can put a finger in your collar because you don't want that too tight that you're decreasing that flow out. Okay, so those are pretty benign things that you can do on every patient. Okay, any questions? Yeah, go ahead.
I don't know if you hit it while I was gone, but with those septic patients when they're really acidotic, is there a chance we could start seeing like bicarb drips, or we need to start doing push bicarbs?
Yeah, and bicarb drips are crap.
Right.
I'm not gonna lie to you. Like in all my years, like you end up working harder when you're doing a bicarb drip, especially on a kid. So I would do, if your pH is like less than 7.2 and you've got a gas, I would ask, I think I would go to probably 7, and then I'd start asking for your amplified carb and do your push. Also look at when you're interpreting your okay, so this is your sodium. If you guys are looking at your labs, is a really easy way to look at your labs. So when you're looking at them and they're giving you all that paperwork, look right here at your CO2, because you don't have to have a venous gas. What you could do is just look at your CO2, and it's going to be anywhere between 22 and 27, which is also correlative with your bicarb within the intravascular space. So if this is 12 or 11, be like, I need to give some bicarb, bro, because they've used everything that they've had up. Does that make sense?
Mhm.
Yeah, drips are shit. The only time, and I don't even know if they're still like in, the only time I've seen them even recently, and I think this is falling out of favor, is with rhabdo. So, but we're still doing it because it makes us feel better. But the literature really doesn't support it. Anything else? It's a lot of stuff. I'm so sorry you guys had to sit here 2 days after the new year and be like, oh, yay, fluids. No, I'm just kidding. All right, you guys, that's it. That's all I've got for you.
Thank
If you have any questions, if not, when you see me around, just holler at me.
Yes, Nicole's sharing her slides. I will put those out in email, and it's also on, we also have this video, so there you go.